Good afternoon, everyone. Firstly, many thanks everybody for coming to this new edition of our meeting with experts. Today, focus on genetic myocardiopathies, and with the participation of very good friends. I would like to thank firstly all of you, all the members of our department. Then people from Salamanca, Pedro and friends, many thanks for the connection and for being part of this initiative of the Cyber Cardiovascular. And also I would like to thank very much and very especially the people who coming from other parts of the country or in Madrid came here today. I would like to thank Roberto, I would like to thank Pablo and Jimeno for Juan Jimeno for the effort to come here and to share with us their experience. And I would like to thank very much and very especially Jonathan and Christine Sedman for coming from Boston to Madrid and from visiting us in this very, very special meeting. This is my very short presentation, my very short introduction, and now I would like to ask our host, Raquel Giotti, to continue and to finish the presentation of the speakers and the meeting.
Well, we're going to start the cases. The first case is going to be the Salamanca's case. But first, I want to say a few words about Cricket and John, our guests today. As all of you know, they are both brilliant scientists. They met when they were medical students, not medical students, but the students, both of them at Harvard University. They have been married for, I think, more than 4 years now. John has a degree in biochemistry and a doctorate in molecular biology and genetics, and Cricket became a doctor, a cardiologist. She did her fellowship in the Mass General, and at the same time, at that moment, he started to work in the genetic department at Harvard Medical School. So she actually became a clinic scientific. That is, as you know, very important nowadays for research, for translational research. And they found the way to complement each other, and during the last more than 30 years, they devoted their careers to understand the basis of inherited heart diseases. And they uncover a lot of the basis of many cardiomyopathies and also congenital heart diseases. And what I want to underline is not only their scientific findings, but also their personal values, and among their values, their generosity. They have trained people all around the world, from medical students to scholars, and this has have a multiplicative effect that has changed the way we understand medicine, research, and also education. So I want to thank you for being here. It's a great pleasure. And if in Salamanca you're ready, Pedro, are you ready? Are you ready, Eduardo?
Yes,
can we start with your case?
Okay. We believe we was in the third position, but I think
so. If you prefer, we can start here. But as you prefer.
Just a minute. Okay.
I thought it was a good idea to start with Salamanca. I know it was in a different order in the program, but
okay.
As you prefer.
Okay.
We can start here if you want.
No, can you see the slides?
Yes, we can.
Okay. So, Okay, first of all, I would like to thank you, Raquel and Paco, for your kind invitation. It's a great honor to Salamanca and especially for me to be part of this meeting. Our clinical case began with a male of 18 years old. He was Caucasian race. He was referred from the primary care physician because she found in the outpatient clinical sinus bradycardia and dyspnea. He was a soccer, he was federated, and he trained every week twice, and he played every weekend a game. His past medical history, he has no cardiovascular risk factors, he has no family history of cardiomyopathies or sudden cardiac death. He was no current medication, and in our outpatient clinics, we asked for the dyspnea and other symptoms, and he was completely asymptomatic. He had no syncope or palpitation or change pace. And the only thing we found in the physical examination was it was a systolic murmur in the apex. This is his electrocardiogram. As you can see, sinus rhythm at 38 beats per minute. All parameters are quite normal, and he has a specific reproducible pattern that it could be normal because he was a soccer player. The Holter confirms the sinus bradycardia. The average heart rate was 44 beats per minute. The minimum in the night it was 32 beats. And the exercise text confirms that he was asymptomatic. He was in a functional class. He reached 15 minutes with a Bruce protocol, and he had a normal blood pressure response and no significant arrhythmias. Because of the systolic murmur, we performed an echo, and let me see the 4 chambers B. And the 4 chamber you can, I don't know if you can see, but you have to believe me that in the apex and lateral wall there is a non-compaction layer, and this can confirm with an echo contrast echo. Our final report in the echocardiography is a non-dilated left ventricle with non-compacted left ventricle myocardial layer in apical and distal septum and lateral segments with a relationship of 2.4, normal global systolic function, and the valvulars and the right ventricle was normal. So, the next step, we made a magnetic resonance to confirm the data of the echo, and as you can see, we can see almost the same things that we found in the echo. This is the short view. The short view, you can see the papillary muscles that they are rotated, and we can see several muscle films in the resonance. Our final report that we have a left ventricle slightly dilated by the imaging of resonance. We confirm a normal systolic function. The patient has several criteria of non-compactation cardiomyopathy. He has a Jacquier, Peterson, and no left gadolinium or no defects of perfusion that were observed. This was our initial family pedigree. He had a very big family, as you can see in the slide. And the only important history was several deaths in 2 uncles and 1 aunt, but it was from a traffic and work accident that it was not related to a cardiac death because they were not a driver or it was just because we had an accident. It was a big stone in the head, I think, in the ankle. So the first question to the panel is, in this moment, if if a genetic test it would be useful in this patient at this moment, or you will see before the family to make the test.
Can we ask some questions?
Yeah.
So I'm curious if, I don't think it's on. Thank you. That was really a very interesting presentation. I guess one question I had was when you showed the pedigree, there looked like there was a child, a younger individual, not just the elderly individuals who had died, but at the bottom of the panel next to the twin girls. And I can't read what that says beneath it. Is that at all informative?
It was a no, because I asked for that, and the patient think that it was an infection disorder because it was several years ago. It was in after the Civil War here in Spain, and he didn't know exactly what happens, but he thinks it was an infection.
Okay. Unrelated. Okay, sorry.
Unrelated.
So you won't help me. I get the message. Okay. So I guess when we see patients like this, we struggle, as I suspect many in the audience will, because the individual right now is relatively healthy. I think that bradycardia, I don't know quite what you mean by federated soccer, but I assume this would be akin to professional. Right, professional. Yeah. But even as a professional athlete, that heart rate is rather slow, to put it mildly. And yet with the normal intervals, I think that it's not providing us anything very suggestive of a particular genotype. I thought initially when you were going to show it to us that there might be some AV nodal disease, some AV conduction disorder, but the intervals were perfectly fine. So I think that bradycardia is important and cannot be ignored, especially in someone who's playing professional athletes. But I will tell you that the number of genes that could be associated with this are many, and many probably is greater than 40. And the evidence that those variants will definitely be helpful in managing this case, I think, is quite small, with the possible exception is if you found a long QT gene. Short of that, as you well know, non-compaction has been identified with a myriad of different hypertrophic genes and some non-hypertrophic genes, including tacithins. So, you know, if you were going to just look at the morphology and say, I'm trying to find the genes associated with that, you know, you might skip some genes, and if you're worried about the electrophysiology, you might include other genes. And this is the kind of patient who, in this day and age, I think you might not do a panel, but you might go straight to an exome. If you were to do that, you're going to have many variants. And so the question is what you're looking for. I think it's going to be an unsolved case after a lot of expenditure. And I'm not quite sure that with this history and no other family history, the genetics would necessarily guide the management. So in terms of the genetics, I would be interested in it from a research perspective. I don't know how helpful it would be in clinically managing it, this patient, unless you end up with a proarrhythmic variant.
I just, as a geneticist, if you have to ask the question, should we do a genetic test? The answer is absolutely always yes. On the other hand, obviously the cost is, it's an important cost question, and I agree with Cricket that there is a finite chance that you would identify a variant that was useful for clinical management, but the finite chance is remarkably small. So I think it's, and actually, unlike Cricket, this week I would say you should do a whole genome rather than a whole exome. But they might as well, he could have that on his flash drive for the rest of his life, so at least it's useful information that it will always have. Sure. I have just as a non-physician, is there any chance that he's taking any kind of pharmacologic agents as an athlete? In the United States, many athletes will take pharmacologic agents that drugs that might or might not be beneficial or harmful. Are you worried about that here?
No, we didn't ask, but no, we asked if he was currently taking some medications, and he said no. So we didn't perform in that item. But I think here in Spain it's not normal that people take some medication to practice sport.
Yeah, that's a good thought.
Okay.
What about you? Other?
Okay, I think you answered the second question.
Sorry, Eduardo, I think there is another question here. No?
Well, actually, I
Yes.
just wanted to ask Christine and Jonathan, what do you think about the cardiac phenotype on echo at this moment? Do you think it's something maybe that could be related to the bradycardia, or do you think it's likely almost a normal heart, or do you think there is some information important now at this moment on the echo? What do you think about the non-compaction phenotype at present in that patient?
So non-compaction can be very, an incidental finding, as we all recognize, and it's, in my visual appearance of it, not very impressive. It's there, but it doesn't very much strike me. I would say what I found striking about that is for a highly trained athlete to have an ejection fraction of 50% as a young person is not as robust as I would have expected. And I would be curious if there was any assessments of diastolic function too, because one of the things that most trained athletes have is incredible capacity to have a high ejection fraction and really robust relaxation. So
furthermore,
yeah.
the days that he was training, it was only twice per week.
Right, that's why I
which
asked.
is not,
it's not
I mean, it's not so professional.
Yeah.
I mean, it's somebody who is involved in regular activity, but it's not somebody who is, doing exercise like 8 hours per day. So I think, and also another good clinical clue, I would say that the left ventricle is a little bit slightly dilated, which is something that we see in highly trained people, but it's not an adaptation that we see in somebody who plays twice per week.
But in those highly trained people, their contraction parameters are excellent, and so is relaxation. So.
I have a quick question for you both. It's just the issue on the acquired non-compaction. Do you believe in acquired non-compaction as matter of during athlete or training or pregnancy? Do you believe in that?
I don't know. Do we see case reports of this? Yes. If you can have hypertrophy of the myocardium from highly trained athletes, I'm sure you could have more hypertrophy in particular segments. So in that group, I think it's probably possible. How common it is or its relationship to anything, I don't know.
And what did you believe, Juan Ramon?
Yes,
what did you believe?
I don't know.
You don't believe? Yes, I know.
No, because I don't think the evidence is robust enough in pregnancy, for instance, because you're not going to put the woman in the MRI magnet to see if to see enough resolution to tell you there are differences. Exercise on athletes, I don't know. They say yes, it might be what you say that is more prominent in imaging, but no, not really. Nothing that appears from nothing.
Okay, so maybe we can continue, Eduardo.
Okay, I think you answered this question. I will explain what we did in Salamanca. In Salamanca, we did a next generation sequencing with a cardiomyopathy global gene panel that included genes that produce cardiomyopathy, and they had several genes that have channels that could be displaying the bradycardia in these patients. The result is this. The lab, we have an external lab in Spain that sent out this report. They sent us three variants that there were no report previously, and it was strange variants that related with the non-companion cardiomyopathy. So what we did is was study the family. This was the mother. As you can see, it has a very similar electrocardiogram of our index patient, and the echo we can observe also a non-companion cardiomyopathy similar to the index case. He has a normal ejection fraction and slightly dilated left ventricle. The cousin, another cousin, have a very similar electrocardiogram. This cousin, he was not a sport practitioner, so it could not be explained by the sport. And the echo, it has also a non-companion cardiomyopathy with normal ejection fraction, and in this case he was quite younger and he was normal left ventricle size. This is our complete family pedigree. As you can see, we made a clinical study for all members, and we did all the three variants from the index case. And you can see that the only variant that co-segregate in the family is the variant from HCCN4, because VO2D3 and DCP in the patients 2.2 it did not co-segregate. He has a clearly phenotype of non-companion cardiomyopathy, and he has only the HCN4. So let's see what our lab said about this variant. He just he has identified in one control in the European class of a total of 60,006 alleles. The predictors, all predictors, SIF, Polyphen, mutation tester, and Dan said to us that it was harmful or very probably harmful. And the bioinformatic study of this protein, what they say is a member of a channel mainly located in the adults in the node synotrial, but in the during the embryology we can also see myocytes that express this protein. This mutation, this variant, is located in the 4' transmembrane helix. That is the main function of this helix is the voltage sensor, and the modifications of the chain of the amino acid is important, as you can see in the Grantham distance score. So the last question I would like to ask to the panel, if after this study, after the bioinformatics study, after the segregation of this big family with several generations, is enough to determine this variation in HCCN4 as a putative mutation, cause of non-compactation, cardiomyopathy, and sinus bradycardia in this family, or you will do extra investigations like a patch clamp investigation, or I don't know, animal models. This is our question from Salamanca.
So I'm unaware of HCN4 being previously reported. I just want to be clear. I know of no reports of HCN4 mutations in non-compaction. Is that correct? Yeah. So if you are a purist, I think he said no, there's no, is that correct?
Did you hear the question?
No, can you repeat, please?
If you put your microphone closer, maybe.
Okay, now?
So
Are there any publications that show non-compaction with HCN4 mutations? previous publications.
Yes, there are several. There are not many, but there are several in JAC or HERDIN. There are, I think, I don't know if Maria can help. I think there are approximately 14 families with this typical with sinus bradycardia and non-compacting cardiomyopathy. But the previous families, they are very small and the segregation is not so strong like this family. But there are several reports about this gene. There are two hypotheses of this gene. People think it could be a problem during the embryology time. And other groups think it could be secondary to the sinus bradycardia, but there are a lot of papers. There are several papers describing this phenotype.
So if it's the cause in other families and you have the segregation that you showed us, you're going to have a LOD score that's going to be quite impressive. And it would be useful to just calculate that. You may have, if you will, the first statistical evidence that shows co-segregation because all four members had both bradycardia and the variant. More than that. 1, 2, 3, 4, 5, 6.
Sorry, it is when you, as you know, the segregation analysis is important to test both the affecteds and the unaffecteds, and I'm a little unclear as to who. I'm sorry, maybe I'm going blind in my old age. Who was actually tested clinically? Was everybody in this on the pedigree tested clinically? They all had EKGs and echoes.
I think all. Sorry, Eduardo.
Okay. All people who has a phenotype of no companion cardiomyopathy, they have an echo and a magnetic resonance to confirm the diagnostic. The two persons that is in the second generation, the 6th and the 14th, they have a non-companion layer, but it's very small. They do not meet the criteria of Jacquier or Petersen, but it's not a left ventricular normal. It's not because it's a different phenotype, and they are carriers of HCN4 variant.
We have questions in the audience, Dr. Medrano.
Hola, Constante Medrano. I asked about the carriers. You have carriers without phenotype. What is the next attitude about that? And I don't know if you test with treadmill tests to these patients. You have more information about the dynamic change in ECG or other change? Two questions: the carriers and the test by treadmill in this family.
Okay, the carriers they will not have the phenotype of no compactation, but they have the sinus bradycardia. And if the treadmill test, they have a normal response to tachycardia. They reach, I think, our index case, he reached approximately the 80%, 86% of the maximal frequency expected by sex and age. It was very normal, the response.
Could we go back to the pedigree one more time?
¿Podemos verlo aquí? La presentación.
So, the issue is, if there's a difficulty in making the clinical diagnosis in individuals who may be negative but turn out to be mutation or HCN variant positive, then doing the LOD score means that you can only include those people who you are sure are clinically affected, and then you're assuming the penetrance is pretty low. That changes the log score calculation quite considerably. So in order to get a log score of 3, you need approximately 10 individuals who are both diagnosable and their genotype is clear. So it's a little bit unclear to me from here. So I mean, I can see that there are about 6 people who are clearly clinically affected. So that information alone won't give you a log score that's sufficient to say, another way, if you had taken the entire exome, for example, and looked for variants that's segregated with disease, probably for 6 people you would have found even 10 different variants in genes that you could make a case why these would be interesting. So the converse is also very important, to be able to identify individuals who you are sure are clinically unaffected and also not carriers. That would allow one to expand the log score calculation or increase one's confidence that there's an association here. I take your point about the notion that the prior probability here for HCN4 is much higher because you've seen other families where HCN4 is associated with some of these clinical phenotypes. But in the absence of that, if you were just doing de novo segregation analysis, you'd really want 10 individuals roughly who were associated with disease and genotype. So I think it's very close, but it is a little bit worrisome right now.
Do the pluses? So there's on the large branch of the second generation, there's a plus at the very end of a male with a dot in the middle. Is that reflecting the HCN positive?
Yeah.
Okay.
Yeah. And that's the concern.
It's hard to see
from here.
Yeah, it's very small in that screen.
Okay.
It's here.
Oh, yes.
And when you have a dot in that individual, does that reflect either EKG abnormalities or just that they're a carrier of the variant?
Yes, sinus bradycardia. There were not other altered pattern in the ECG.
Okay. So great case.
Thank you.
What did you do with the athlete?
What did you do, Eduardo, with the proband?
Nothing. We didn't start the medication, and because he was very interested with the soccer, we at this time we didn't stop. We recommend just not another sport like anaerobic sports, but we are going to follow him in 1 year, more or less.
Okay, thank you. So you will tell us. Yes, of course.
Okay.
It's a brilliant case, Eduardo. Congratulations. I wanted to ask Cricket, because maybe the case here is to maybe preventive treatment with any enalapril or something for somebody who is a carrier of a potential cardiomyopathy with a slightly dilated left ventricle. What's your feeling about preventive treatment in individuals with very mild disease or with no disease but who are carriers of genetic variants?
Yeah. So for this particular, I think that's a gene-specific question, and certainly for this individual, I know of nothing that would be a direct modifier of HCN4. Frankly, what we would probably do in such an individual is put it in a reveal for continuous monitoring of arrhythmias for him, because I fear that's a greater worry right now than his potential for DCM. Given that his parent doesn't have profound DCM, and an uncle, I think, was a carrier, also doesn't have one. I'm more worried about the rhythm. But we probably would not do anything right now and follow them as they're doing.
But there were no pacemakers in the family, there was no sudden cardiac death.
Right. Nothing.
So
right. It's just that worry of,
Yeah. It's now that you know the gene.
Yeah, in previous papers, the big problem of this gene is that people need a pacemaker at young age, approximately in the fourth decade. But there are no problems, big problems about the heart failure. So that's the reason that we didn't start, and because he practiced sport, he practiced approximately between 7 and 10 hours a week. So that's the reason that we didn't start. If it was another gene or another cardiomyopathy, probably we start with an Alapril or another treatment to prevent the dilatation of the ventricle.
Great. So we are going to go to the next presentation. The next presentation is going to be presented by Dr. María Ángeles. Oh, I'm sorry.
In that case is better, and the non-compaction is not so evident as a doctor, but we feel that he is also affected. He also has no fibrosis on MRI. And this is a small genetic pedigree in the family. In that case, for genetic testing, we first screened the proband son because he was the first patient we saw in our clinic in 2012. And we did an NGS panel of 35 genes in that moment. And again, we found a truncated variant in alpha-actinin, as you can see there. And we found that also the father and the sister were carriers for the variant. So just to make a brief description of the alpha-actinin protein, this is I will be able to say it in English, an actin-binding protein. It's a major component of the zeta disc, and it has several important roles in cardiac cells. But especially, this protein is essential for actin filament organization, and it also interacts with other proteins, such as titin. So it plays a very important role in the interaction between the sarcomere cytoskeleton and the muscle membrane. So at least from a pathological point of view, it makes sense that this protein can be involved in several cardiomyopathies, such as HCM or non-compaction or DCM. In fact, there are several reports that have found some missense variant in alpha-actinin. Here in this slide, you can see 7 families with some missense variants in alpha-actinin that have been reported to produce several cardiomyopathy phenotypes, very different, such as hypertrophic cardiomyopathy, DCM or LV non-compaction, and even a same mutation, such as the one we have here, in 2 different families, have shown to produce DCM or LV non-compaction, and in another family, hypertrophic cardiomyopathy. Also, with these missense variants, it has been described a huge enough strong evidence. So it has been recently published that missense variants are not so uncommon in population, as it was described in this recently published work. And what they found is that there is no excess of rare variants in HCM cohorts in comparison to population controls, as the ESAC population. However, instead of the missense variants, the loss of function variants, the nonsense variants in alpha-actinin, are indeed very, very or extremely rare in population. And when we had a look at what is reported in literature in patients with loss of function variants, there is also very little information about very few patients with different phenotypes, but no data regarding segregation in the family. The variants we found in these 2 families are localized in important regions, domains of the protein, such as the rod domain here in this protein, or in the C-terminal, in the calmodulin-like domain of the alpha-actinin. So just to briefly summarize, these are two small families with a different phenotype, but they share a truncated variants in an unusual gene with no evidence of sarcomeric genes in the NGS panel tested. And this is the questions we wanted to make to our experts and to the rest of the audience. If with all this information, should we consider these nonsense variants in alpha-actinin definite causative mutations? If we can use this information for genetic cascade within these two families, or if do you think further studies are required, and in that case, which ones? And that's it. Thank you.
Thank you, Maria. First of all, I want to know if you can hear us in Salamanca. Eduardo, can you hear us? I don't know, maybe we have lost...
Yes, we can. Okay. No, can you hear us?
Yes. We can.
Okay.
So do you have any questions from Salamanca?
Do you have any questions?
We were not able to hear the whole case, so we apologize, but we missed the beginning of the case. We are sorry.
Okay. So maybe in the panel, do you want to try to answer some of the questions Maria Angeles just asked?
So we became very interested in actinin because we also sometimes find that, and certainly when Raquel was in the lab, she found a couple of mutations and went back and looked at these families with these presentations. I'm very struck not so much by the missense mutations, although in one of the prior publications there appears to be segregation of a missense variant, but the loss of function mutations in actinin are extremely rare and exact. The probability for loss intolerant is 1, meaning that this gene is really rarely deleted in the human genome, and I think that makes it much more compelling to be a definitive cause of a cardiomyopathy. We also know from some studies that have been done at a basic level that the carboxyl end of actinin is critical for tethering titin to the thin filament and thick filament. And when you truncate it, that those cardiomyocytes are unable to make and to restore sarcomere after any stress. So there's some basic studies that also, in my opinion, support the idea that loss of actinin may in fact damage your ability to repair the sarcomere from any other stress. I would have predicted that would have caused DCM, not HCM. Yeah. But I have to tell you, I've seen too many mutations where I would have predicted A and the patient has B. So I think this is, I think these are causal mutations. I think that the manifestation of these mutations is really just beginning to be discovered, and I congratulate you on really sussing this out, and I hope you write it out, up it, and publish it.
We hope, yeah, we can do that.
So that was a very nice presentation. That was very clear and very helpful. I just wanted to distinguish, actually it's a question that Xavier asked before. Clearly in this case it's a cardiomyopathy. I think the characterization as to whether it's HCM in particular, I think is really quite important. And I say that because as we're hearing, the molecular mechanism by which you get the clinical phenotypes that you're talking about, the molecular mechanisms actually differ. And right today there are no drugs that treat any of them, so in a way it really doesn't matter. But hopefully next week there'll be drugs where you'll actually treat different cardiomyopathies, and you wouldn't want to give the same drug to a patient who had, let's just say, a myosin heavy chain mutation to a patient that had a tight mutation. That would, both of them are cardiomyopathies, but that's not going to do the patient any good. So if the question is this a disease-causing mutation? I think the answer is clear, yes. Is it causing it by the same mechanism that, say, a myosin missense mutation is causing disease? I think that's not so clear. And I think Cricket's going to talk actually about some assays that you could consider. You asked about future directions. Yeah. Some assays that one could imagine that you could test either in a pretty quick way, actually, or a very useful, and this is almost an advertisement. So now there's using human cardiac tissue, discarded cardiac tissue from a patient with one of these cardiomyopathies. You can actually measure the rate of the amount of myosin ATPase activity, and you can measure the configuration of myosin heads.
Yeah.
And it might be if one had any explanted tissue or tissue, it would be really interesting to test on one of these family members. It's not been done yet for actinium.
Well,
so.
actually, we have, because when we put the patient in the pacemaker, we took advantage of the procedure and we took a small piece of biopsy. Yeah.
We would love to talk to you.
Okay.
Okay. So
Let's move to the next presentation.
All right. I wanted to ask, taking the opportunity, because you presented a paper by Wells, or I don't know exactly the name.
Wells, yeah.
And that's the concept of etiological fraction for genes. I understand that can be helpful, and you use it, probably. Do you use it? And then the second question is, would you use that to say that that is not a disease-causing gene, or to exclude it because it's not overrepresented in a disease population?
I think you know the answer to that.
I think we all know.
One never says it can't cause disease.
Yeah.
That is a population-based analysis, that it is statistically less likely across the population to be a disease-causing gene than another set of genes. But in any one family, unless we had profound population evidence that the mutation that family has is common in the population, I don't think you can exclude it. That's pretty easy to assess actually from loss of function, because we assume that most loss of functions do the same thing. They truncate the end of the protein. But for missense mutations, that's impossible without functional studies of that very missense. So I think there's a lot of emerging evidence that actinin is going to cause disease, and I don't quite understand why they didn't see some small signal. It may have some geographic prevalence in parts of the country, in parts of the world rather than in other parts, and theirs was largely a UK and US. So some of these variants may have founder effects, but I also think that the penetrance of these, as you showed, is so different that they may be being missed, and understanding that would be very important.
Yeah, sure.
Yeah, I just want to echo what Cricket said. Clearly, loss of function variants are different in the way you categorize them, and it's unclear how they were binned in the Walsh, to me, how the loss of function mutations were binned compared to the missense mutations. The other, I think, important question goes back almost to the one that you asked at the beginning, is this, what kind of a cardiomyopathy is this? It's possible that these people will show up in HCM clinic in, let's say, Spain, but they might show up in some other cardiac clinic in some other part of the world. Yeah. So that would sort of reduce the apparent burden.
Okay. Shall we move?
Next presenter, I think, is Juan Ramón Jimeno from Murcia.
I will present a case which has been for ages in our clinic. This is the first video wouldn't work when I have a plan B. Well, this is a family. We started for the pediatricians, starting seeing this couple, a brother and a sister. When they were diagnosed, the brother was 4 years old, and he complained of tiredness and exercise capacity, problem with exercise capacity. And then he was diagnosed with restricted cardiomyopathy. He underwent metabolic studies, and they came up normal. And then the sister was diagnosed years later. When she was diagnosed, she was 8 years old. She was fine, doing well. Parents refused the studies, screening, because they felt well, and they find the sister, there was another sister who came later, and she was fine. And the phenotype was restrictive with non-compaction. That's an MRI performed years later. I'll show you this is the brother, wouldn't work. And the sister is working here, but it's not there, sorry. I'll try again. No. Well, that's the ECG of the brother. He was now 23 years old. That's a striking P wave, and PR interval is prolonged PR interval, and high voltage QRS, and repolarization anomalies, as you can all see. That's the echo video of the same patient. He is now 24 years old. He is now with heart failure. He's got very enlarged both right and left atrium, and he's got restrictive phenotype. His ECG now is 26 years old. He's not doing so well, and he's got ECG echocardiogram. He's got very enlarged atrium, right and left atrium, restrictive physiology, non-compacted left ventricle, and very high systemic pressures. And that's her ECG a few years later. She is now in atrial fibrillation. She was admitted with heart failure and rapid atrial fibrillation, and underwent AV ablation in recently a few years ago. And she's doing reasonably well. And then the mother accepted screening several years later, and came to our clinic, and she's got a very abnormal ECG as well, and she has the same phenotype as the daughter and the son. Is not so striking, but is restrictive phenotype, left ventricular non-compaction, and also had bicuspid aorta valve, aortic valve, and she's now 47. She's doing reasonably well symptomatically, despite the very huge hepatic veins, and she's doing well. So then we got 3 affected members in this family. The 2 very early presentation of restrictive cardiomyopathy, which is unusual to have such a long natural history. Do you think so, or do? Well, we can make a stop here, if you want, and I have your comments or views. Is that right?
How thick is the myocardium?
How thick? Of the
mothers look very hypertrophied.
I think it was 16 in some places. You're looking at the short axis.
Yeah, no.
Is that the short axis view? That's here? Yeah, I think it's the right ventricle here, and is the pericardium with a mild pericardial effusion, which is not that thick here because it's the right and the left. Probably it's not good picture. And she's got some hypertrophy. Yes, I agree. Yeah. Yeah, well, obviously she didn't want to have a MRI scan, and she's not very adherent to clinics. So she's not coming very frequent. So
and do we know anything about her parents?
From sorry?
The mother's parents in terms of their health?
Well, the mother is fine. We've seen her. We've seen the sister. Yeah. And we didn't see the grandfather, the parent, the grandfather. But we know he died during a heart operation a long time ago in another institution. We don't know more detail from the grandfather, but it seems to be that the disease comes from the grandfather,
right.
Probably.
So you have dominant transmission of I don't really think I would call it accelerated penetrance. We see this in some of our hypertrophic families, and I can't explain it, where a parent will present later in life, or at least as an adult, and they will have children who present earlier. I think we're quicker to image than we were when that mother was a little girl, and I think that helped make the diagnosis of a child who presents with fatigue. Otherwise, he might not have presented till he was around 20 as well. So I'm assuming you must have done genetic testing in these individuals. And do we have a guess? Are we going to tell, or are you going to?
Yeah, well, you want to give your guess?
I'm curious. You know, the audience.
You know the answer.
Any idea in the audience about the etiology, or are there any
the genetic
questions?
etiology?
The genetic etiology, or any questions about the phenotype? Something.
Constant.
Pablo.
Please give your views.
I was going to ask, how many of you, could you raise your hands, thinks that this is sarcomeric? Sarcomeric gene behind this. Nobody?
I do.
It could be an option.
I think maybe it's not quite fair. The prior probability during this session is
Yeah.
Can we get a vote for thin versus thick filament? Who votes for thin? Thin filament. I'm going to vote for troponin I, so I'm going thin. I could be wrong again.
Any idea from Salamanca?
We are discussing in the table. I think it could be the big the MYH7 gene, a sarcomeric gene.
What about filament?
What about?
What about?
It could be.
Is it in your list?
It's filament.
It's the new kid in the blog that is fascinating.
Fashionable.
What do you think, Roberto?
Yes,
I do know the case.
Yeah, but we don't know with just 3 cases. Yes. We have the histology because the probe underwent transplantation very recently in December. So that's the heart. The heart weighted 346 grams, which is not very high, which is borderline as expected, and it's got it looks fibrosis at the macro study, and clear non-compaction of the left ventricle mid and apical segments, and with subendocardial fibrosis here, particularly here. I asked the pathologist whether there is a line of fibrosis here, and he said it's not. Is to do with the fixation technique, and that's the histology. There's patchy fibrosis with some disarray, mild disarray, and myosite hypertrophy with some nucleus here, nucleus here and there, fibrosis here. And he found particularly interesting is that what he called eosinophilic myocytes here, and he said it is not apoptosis, and it's not. Don't think this is ischemia. This could be. We could look inside and see there is a deposit of something, particularly when he came the gene testing result, and she is the sister. They both look not entirely normal morphologically, and particularly the sister has a white neck and webbed neck, and we thought that could be a rashopathy or something. We sent the case to the medical genetics, and particularly because she wants to be mother as well. So that's another issue of discussion, and she's not very tall, but the family, the father is not very tall. So that's average in the family, not in the affected, and well, all sort of different panels for looking for other genes or syndromic cases, rasopathies when all normal, and she also had a C1, C2 spinal fusion that there was reported in the examination. And here it came the result from the genetics. That's a large panel to nearly 200 genes, and we wouldn't. What we found that could be the case, that would be one of these two genes are associated to rasopathies, maybe, and less likely the other three. With the channel, we didn't know that was a causing gene, and then we focused on these 4 genes. Then we ran segregation, and then MAP2K2 and HRAS didn't segregate with the family, and they weren't present in the sister who had the phenotype of rasopathy in particular. And it came that filamency was associated with the 3 cases of the cardiac affected phenotype. So that's and that was a missense mutation, not described, and that was the gene testing so far, but that was performed in 2013. So we might repeat it with a larger panel, or is there the family an issue for exome analysis looking into other genes, or are you happy with the filament?
To me, I have to recognize that I wouldn't have thought in filament as the first choice. The only thing that now I'm realizing is that AF and flutter was maybe a bit slow that you can expect from a young patient. I don't know if this was under medication or not, because the ECGs you showed, the AF was not it didn't have a very fast heart rate.
Yeah.
But in any case, this is something that I have realized now. You show the results of the genetic test. I wouldn't thought in filament as the first choice. In that case, I have to recognize. But you will give us the solution, I hope.
No, just this is the end.
I don't know. I don't know if any of you think that maybe the low heart rate of AF in such young patients maybe could have been a clue to think in that possibly diagnosis. I don't know. What do you think?
Well, the boy, I agreed with the boy. The heart rate was particularly normal and well controlled with carvedilol. But the girl, the sister, she had to undergo an AV node ablation because she was admitted on several occasions because of rapid AF, heart failure, and because the boy has a slightly different phenotype with a more systolic impairment. The sister is more restrictive and less systolic impairment. She's got a high pulmonary pressure as well, 55 millimeters, estimated millimeters mercury, and she's doing well. She's more stable, but but they've been quite a long way with the disease with reasonably good quality of life till very recently.
I've got one question. Sorry.
No, only a comment. Probably the importance of the mixing of rasopathy genes and sarcomeric genes is unknown, but there are some description of very strong phenotype and early in children and in infancy, who mix the 2 ways, no? And probably the HRAS plus filament. There are description of other sarcomeric, I don't know, filament with rasopathies. probably this is important in my opinion, the addiction of the phenotype and the early presentation for the
probably that could be an explanation for the boy, not for the girl, but for the boy. Yeah.
Well, I think filament could be the gene responsible for the disease. In fact, filament G has been related, miscellaneous mutation of filament G with restrictive cardiomyopathy, two big families with a real co-segregation. We know that truncating variants has been related with dilated or arrhythmic cardiomyopathy. But I would like to know your opinion about the relation of filament, missense mutations in filament and hypertrophic cardiomyopathy. Do you think, well, what do you think? Do you think it's a risk?
We have a debate of that in the Seidman household. I'm not convinced that the missense mutations cause HCM. John, I think, is more skeptical or positive they do. I think that the compelling evidence with DCM of loss of function mutations is really quite established. And I love the idea that the HRAS variant might have in fact allowed for earlier penetrance. I don't know that we can determine what would be a driver of a hypertrophic response if that could be an attempted compensatory restoration of cardiac filling, especially when you have restrictive physiology. So I wouldn't bet that you couldn't get some hypertrophy, but I personally think it's secondary to the restrictive physiology and or the preceding dilated cardiomyopathy that these filament mutations get. I don't think it's a primary HCM.
Okay,
and you do get a lot of restrictive physiology with troponin I's, but more hypertrophy. I agree, Pablo.
First of all, I think in our laboratory, the filament C professional is over there. When Raquel worked with us, she was the person who spent more time thinking about filament C variants than anybody else in the lab. So we should ask her. But I wanted to say two other things. One is these tests were done a little while ago, and the genetic tests, and I don't know, for example, whether they would have picked up copy number variants. So it's possible that you could have, say, a copy number variant in a troponin I that was missed. It's well worth. I mean, again, it depends on the cost, but doing a whole genome of this person would certainly lay a few. Well, I would do a whole genome, but anyway, several concerns. It depends on, again, the cost, but I think it could be a useful thing to think about. This issue, one place where two Seidmans really do disagree is on the synergy between two different variants, for example, a RASopathy and a filament C. I mean, in mice, we have very, very little evidence that if we have a mutation in one pathway and in one hypertrophic or one cardiomyopathy pathway and in another cardiomyopathy pathway, and we put them together, there's very, very little evidence of synergy, of exacerbation phenotype. So obviously we can't do that experiment in humans, but it just makes me very nervous. I mean, so filament C may not, after all, actually affect sarcomere enhanced contraction and impaired relaxation that we associate with HCM. It's clearly a cardiomyopathy, but it's not going to do enhanced contraction and impaired relaxation. And actually for the RASopathies, the same question is out there. So if the
we've never made it a RASopathy model.
You're totally. No, this is an undone experiment. But between the two of us, I always think that there's very little interaction, and Cricket always is very concerned that there's lots of interaction. So you can have both answers.
Only if this helps at home. We have a family which is very, very similar to this one. And actually, Alejandra might know because she has been studying that family for a long time. But they have the pedigree is almost exactly, except that there are not 3 children, it's 2. One of them has an ECG which is exactly the same than this one, without hypertrophy. Yeah. But the other one, who was the proband, was diagnosed as HCM. I mean, with hypertrophy.
Was diagnosed with HCM.
And he came to us. And then the mother was diagnosed with restricted cardiomyopathy with a mild hypertrophy of 14, 15 millimeters, depending on the sonographer that day. Yeah. Okay, so my view is that probably, I think there is a case for HCM and filament in certain families. Although they probably, as you just said, some of them exhibit a restrictive fillet pattern. But I think there is a real case for hypertrophy, and depending on the proband, if the proband that comes to your clinic is the one who has hypertrophy, you will label him as HCM. So that's the way I see it. And it's just to support
John, I get it. But I would argue you should check the HRAS pathway in your hypertrophied family. No, I mean, I think that this is where this gets really complicated, and that's the intriguing part about it, because if we understood what modified these variants, we would understand better how to unmodify them in a productive way. But I am driven by the recognition that loss of function of filament really just yields DCM. So that's my advice.
Thank you.
Any questions from Salamanca? Eduardo?
No questions.
I have a question, Raquel.
Pedro.
Raquel, hello. I have a question for Dr. Gimeno. First of all, congratulations for the case. It was a very good case, very well documented. My question, Dr. Gimeno, is the knowledge of the genetics testing going to change your daily clinical practice with this patient or with this family? For example, you have told us that the girl wants to be a mother. So
yes,
is the knowledge of the genetic testing going to change your advice to be a mother, or?
My personal view is that she is under the counseling of the special department, the medical genetics, and they normally run all the counseling and the support. But I don't think she's in a position to be mother with that with the cardiomyopathy she is at the moment, because she's now stable, but she went into AF, she's with a pacemaker, and she's got raised pulmonary pressures. But if that wasn't the case, we don't know. The report is we believe filament C is part of the causing. I mean, it's a causing or is a co-causing disease expression in this family. We believe that, but there must be something else. And in that situation, I don't think our medical geneticist will recommend pre-implantation now test to rule out the presence of a mutation. That's probably will not be recommended, and they will go for other reproductive strategies or something. That will be my. But yes, we normally in these cases, if they want to be mother or father, we send to medical genetics, and they can have babies without the mutation we've done this before. We have very good relationship with them, and the process is quite long because it takes a couple or more years going through the counseling, and then there is a panel, and then there's a you all know, and then but yes, it's possible and feasible, yes. And there's an important for this family, obviously for the two boys who are affected. There's not gonna change medical management, but there's another girl who is free of the disease. We're gonna follow her up, but as she is now more than 25, she's not phenotype so far. I think we could discharge her as from follow-ups and things. Any other comment? No? No.
Thank you.
Would you do the same, or how about the...
I'd be more suspicious for the pre-implantation use of this information. I would be, I would lean towards using that information depending on the parent.
You wouldn't?
And I
No.
would. I
You
would.
All right.
I would be more concerned because, you know, you have not done everything, but there's a dominant transmission here that's undeniable. So the offspring, forget the daughter, the woman who maybe shouldn't have a pregnancy for health reasons, but the man who's been transplanted has a 50% chance of transmitting. And in that regard, you know, if there was desire for his offspring to know more, I would probably do an exome, but I bet you're not going to find much more than what you have right now.
Right.
And it's probably, you know, the film mutation.
You find it feasible with just the information we've gone so far with the
Well,
genetics?
you know, you'd have to hedge some, but yeah, I would personally err more at saying this is highly, highly suspicious as being causal.
Great, thanks, Anna. That's good.
Next speaker is Dr. Pablo García Pavía from the Hospital Puerta de Hierro in Madrid. Thank you, Pablo.
Okay, so thank you very much, Raquel. Thank you, Paco, and thank you all the colleagues from the Gregorio Marañón for inviting us to share with you these moments and spend some time with Cricket and John. I'm going to show a case that we have entitled Untreatable Apical Hcm. Okay? So this is a 29-year-old woman who came to see us in 2011 because she developed palpitations and some chest pain. She went to his primary care doctor, and on ECG there were some signs of left ventricular hypertrophy, and there was no arrhythmia, and because of that she was sent to the cardiology department. We performed an echo on her and showed these findings. Well, there is a clear HCM pattern with a predominantly hypertrophy in the apex. Okay, so at that time she was in functional class 1, or we will say that maybe 1, 2, but she was doing very well. She was doing very well. She's a pharmacist and she was working and doing very well at that time. We performed Holter on her, and we had a couple of rounds of non-sustained VT, and we also performed an MRI, which I have not brought here today, but it just showed, well, same findings than the echo, with a maximal wall thickness of 24 millimeters, a little bit higher, and some patchy findings of left gadolinium enhancement in the typical junction points of the left ventricle with the right ventricle, so very typical of HCM. And because of the chest pain, at that time, it was requested a coronary angiogram, which was normal as expected. This was the family. She was the first one to be diagnosed with the condition in the family, and there was no history of sudden cardiac death in the family as well. We performed NGS genetic study on her, and what we found was that she was carrier of 2 mutations. Both of them had been linked with HCM in other publications. And when undergoing family screening, well, we were not very lucky because she had no relationship with his father, and there was no opportunity to screen him. But we were able to screen the mother, who was carrier of 1 mutation, but the phenotype was completely normal. So this is what we had at that time. She had been under our curve since then, and eventually got pregnant, had the child, and in 2014, when coming back to the clinic, what she told us is that she had a lot of shortness of breath, and she was in functional class 3. And interestingly, this appeared after the pregnancy, which is something that has been described before, but for us was a surprise because she was doing superbly well before. At that time, we had the European risk score, which is another thing that we can debate here, and putting all the data into the calculator, what we found is a risk score of 4.8% in the next 5 years. So an ICD was implanted on her. And at that time, this was her echo. You can see here that the hypertrophy, I think, it has not changed substantially, but you can see that the cavity is smaller and smaller. And you can see here, I think I have a pointer. Yeah. So here you can see that this wall is collapsing and hitting into the papillary muscle. So there is virtually no cavity at all. So this might be causing her symptoms. Well, this actually is causing her symptoms. So just to be sure, we decided to perform an exercise echocardiogram, just to confirm that there was no left ventricular outflow tract obstruction. And, well, there was an improved relaxation pattern. And the NT-proBNP levels, who had been below 1,000 before, now were all in several tests, blood tests, they were above 2,000. And this had happened since she became symptomatic. Well, we put her on some furosemide and some bisoprolol to try to ameliorate symptoms, but she did not respond well, and actually did not tolerate it very well with hypotension. She had to quit her job, and she could barely take care of her son. So she was very symptomatic at this stage. And we decided to try with trimetazidine because, well, just to try something, I guess. But there was no clinical improvement at all, and we had to suspend that. So to make things worse, we got an ICD shock in November 2015, and that was because of a supraventricular tachycardia. So we decided to put her on amiodarone also to try to prevent further discharges. And here comes my first question, which is what would you do with a patient like this one at this stage? And I have brought some options, which is verapamil, atenolol, try with amlodipine, maybe that can help with the chest pain. Try with ranolazine or put her on more diuretics and see if that improves. Does anybody want to?
The fellows at the bottom.
Yeah. Yep.
Any answer?
What? Try with some different diuretics.
Hello, Eduardo.
Can I just ask while you're getting an answer, why does she have chest pain?
Why? Why did he have? Well, I think it's microvascular dysfunction. Probably that was the reason, I think.
Okay.
What is the heart rate and heart rate during exercise?
That's a good question. I haven't got the answer for that, but I think well, we did some cardiopulmonary exercise test on her, and she did not last much in the treadmill test, so we had to stop that. But I will not say that was very high. I think it was under control. Not very low. No, there was no chronic. I think it was around 60, 65. I mean, no problem from that point. I mean, that was not so. Yeah.
A previous question. Pregnancy.
Yeah.
Before pregnancy.
She was doing okay.
You have the diagnosis.
Yeah.
And the genetic test.
Yeah.
And what is your counsel? And what is the?
What did we say to her? Yeah, well, we tell her that as most of the HCMs, they do fine during pregnancy. So at that stage, with a low NT-proBNP and with no symptoms at all, we told, well, she did not ask, but if she had asked to us if she could have undergone pregnancy, we would have told her that she was allowed to. Not at this stage, I mean, it was before everything started. And regarding genetic counseling, we told her what was the situation. She was a carrier of 2 mutations, what were the reproductive options, and she decided to have it the natural way. So.
And you have a genetic study?
Well, we do not perform genetic study on children. I don't know what do you do over there, but if the children are asymptomatic, we follow them. We have chosen to follow them clinically and wait till they are older than 16 to decide for preventive, pre-clinical genetic testing. I don't know, what do you do in the US?
We do the test usually, talking with the families, explain the possibilities, and we prefer to know the carrier state for start the following in different phases. The most part of the parents are worried about that, and if there are any type of carrier, the problem in these 2 mutations, if you are only one, I don't know what is the information about that, but if the parents in general, in our experience, are more comfortable if we perform the test in the children.
It's a parent's choice in the U.S. It's not mandated one way or the other, and parents often choose to have blood banked at the time of delivery, cord blood, even if they don't want to know, just so that it's available and it can be, analyzed subsequently. I would say that in the patients that we take care of, the vast majority of them want to know, and they want to know not because they're not going to have good pediatric care, but because some of the children don't need it. And it's very hard, in particular, for young little boys not to think they're going to grow up and be the best athlete in the world. And so I think it helps the parents, in my experience, of directing their children into exercise and opportunities that are appropriate if they are mutation carriers.
But in this case, in this particular case, this is a compound heterozygote, and the chances that the child will inherit both variants is smaller.
But
so
you still could know.
It could happen, but it's obviously lower.
And in Salamanca, what are you doing in Salamanca about genetic testing in children, Eduardo or Pedro?
Okay, in Salamanca, when it's a disease that begins in the childhood, we usually do in the children, and when it's sarcomeric or another kind of disease that begin in the adult age, we ask to the parents, and they have the final decision. They said yes, okay, or not. We are going to wait until 18 years old.
But that's interesting that you have said that, because I would have expected that with all the restrictions with the insurances and all that, I would have bet that in the US many people would have been against testing their children.
I think it has a lot to do with, like you, we're in a tertiary referral center, and we see, frankly, the families who are sickest.
Yeah.
So, there's a bias of who we see unequivocally. Not all of them do, but the majority of them do. Can I ask another question about your case? Because in your options, you didn't give me the one I would probably suggest.
Okay.
So, do you use disopyramide here?
Well, we use it regularly, but we use it for the ones who have left ventricular outflow obstruction, not for the ones with apical hypertrophy. We eventually use it with people with mid-ventricular obstruction, which probably was a case here. But we did not try, also because he was on amiodarone and we wouldn't mix both.
Right,
but
we
probably,
wouldn't mix both either.
Yeah, but we could have switched her from amiodarone to disopyramide. That could have been an option. Yeah.
So the reason I ask about what you think is causing her chest pain is with that degree of hypertrophy in the pap muscles, I think that there's a fair bit of diastolic compression of intramural coronary arteries.
Yeah.
And if you can improve relaxation even a little bit, we've seen quite striking improvement in symptoms. It would not be something you usually use for ischemic symptoms, but if you think it's a diastolic dysfunction, and in that regard, I think disopyramide clinically has been useful.
Anyway, at this stage, although the chest pain was still present, she barely exercised her. So that was not now a main issue. It was more like the shortness of breath, the problem, and she was unable to take care of her son. So that was the most problematic scenario at this stage.
And about the phenotype, would you call this phenotype apical HCM? Because I mean the wall thickness in the septum, it was about 24.
Well, I think I will call that, obviously this is not a pure apical HCM because you have also hypertrophy at the mid-ventricular segment, but it has hypertrophy at the apex. So depending on what definition are you using. If you want the Japanese perfect apical HCM, this is not the case.
I totally agree. I think that there's an issue with the classification of the apical HCM.
Okay.
I think Juan
Ramon
has
I have another tablet to the list of medications.
Oh, great!
If you will. That's a new one. That's very nice. Will you use the MIG 461, the mavacamten, which is you will probably in.
Can we wait for that answer?
All right.
Can we wait for that answer, please?
Sorry for that.
Okay. So let's go ahead and. Can we get back to the slide, please? Okay, thank you. So we decided to try with ranolazine, which nobody has pointed out here, which is interesting. Okay, but I can make the story short. It did not work either. Okay, so what happened is here you can find some pulmonary exercise tests, and you can see that it was not in the degree that we usually use for indication of heart transplantation, but it was quite reduced for somebody who is 35 and who is a mother and has to take care of the children. Actually, you can see here that the predictive value of somebody with that age is around 50%. And I can tell you that she came to our clinic and she was crying in the clinic saying that she could not live like that. Yeah. Okay, so at that stage, we were in 2016, which is here. You can see that the echo, sorry for the quality, but you can see here. I will call that apical HCM, Raquel. Yeah, and this was the situation, okay? So with that, here, to sum up, we have a 35-year-old woman, non-obstructive HCM, severe hypertrophy, small ventricular cavity, functional class 3, and bad response to pharmacologic therapy. No effective pharmacological alternative at this stage. And now it comes. Juanra. What will you do next to improve the clinical situation of this patient? And again, we have some options. One is heart transplantation, apical myectomy, just go away and try to implant an LVAD. Clinical follow-up, no changes, we have no alternative, or wait to mavacamten. Maybe we can start with that one. Cricket.
So just in the interest of full disclosure, Cricket and I are founders of Myocardia, and Cricket kicked me when I said mavacamten. So, they are about to start a phase 3 trial, so it depends on your thought about experimental phase 3 trials.
Yeah, but the phase 3 trial is going to start is for obstruction, isn't it?
Obstructive. It's an obstructive. It is. It's obstructive HCM.
So she cannot get into that trial.
Right. That's true. That's true. And I will tell you that, and this is public knowledge, and just to be clear, John nor I, and certainly not John because he's not a doctor, we're not involved in any clinical trials related to this drug. And if my patients are interested in involving in the trial, it has nothing to do with me. So it's again, you know, what I can tell you is we've seen the use of the drug in mice and in stuff I'll tell you about tomorrow in specimens from heart tissues. And we think that it is a very powerful medication for improving relaxation. And the ability to have that opportunity to give to patients is something that we're very excited about.
Yeah.
I'm excited about as a clinician because that's why patients are sick. It's diastolic dysfunction. It's not hypercontractility. And I don't know if they have compassionate use for this drug, but
Not
there's
that
an
I'm aware of.
opportunity. I don't even know how it would work because it's an FDA-run trial, et cetera, et cetera. So I'll be curious what other people want to do with this lovely young patient.
Maybe the transplant guys.
I would first try disopyramide.
Oh, that's good.
Well, at that point, I think we will try to do the rollout for heart transplant and all the explorations. Also with right catheterization to see if she has developed pulmonary hypertension that is quite frequent in this restrictive phenotype. Also the mutation in the heavy chain is in the converter region has a really bad prognosis, and many of those patients finally reach a heart transplant. So it would be my first option, and I would leave the LVAD just in no treatable moment.
Yeah. Well, LVAD is really tricky in these hearts because the cavity is very small, so you cannot place the cannula anywhere.
That's right.
So I will not go that way. Heart transplant is certainly an option, but the problem with that is that she was sick. She's 35, but you are like, well, it's not so sick. I mean, she's doing very bad, but we have so many DCM individuals with inotropes, such a waiting list that is quite tricky to decide. But certainly there was little to offer her. And at that stage, we decided to try with apical myectomy. I don't know if you have experience on that, but by that time, what we were is that we had read some articles by the Mayo Clinic group, by Dr. Saf, and we had the options to bring him to our hospital. He was very kind of coming to our hospital because he was coming for a meeting that we had organized. And he told us the experience that they had over there, that they had operated 62 individuals. That was the ages. 2/3 women, which is interesting because women, in my experience, they have smaller cavities. So maybe with the same degree of hypertrophy, they might do worse and maybe get these symptoms. And preoperatively, 91% were in functional class 3-4, and these were the reported outcomes from their group, which was 95% alive 1 year after the operation, which is remarkably higher. Well, it's quite high, but it's remarkably, the mortality is remarkably higher to the one that they have reported in the typical myectomy, in the left ventricular outflow tract myectomy. And interestingly, 74% of their patients, they reported very good outcome within functional class 1 or 2. For those who do not know the technique, well, this is what we offer to our patient. And for those who do not know the technique, well, what you do is you cut the heart by the apex. You go into the left ventricle cavity, and well, somebody has described this like taking out pieces of melon, but this is what you do actually. I mean, it's like I think Juanra said one is like the kebab technique, okay? So what you do is you bring out some tissue, and what you do is you create a new cavity. So we were honored that Dr. Saf came to our center and operated with Dr. Forteza the first case, which was this lady. Well, this is the result. we had some problems during the operation because when they finished, what happened is that there was a flail mitral valve, so they had to reconstruct the annulus. You have seen that there is a ring there and put some new cords. But after that, everything went very well. She was discharged 1 week later, and 1.5 years after that, this is the results that we have. She now takes care of her son. She has not returned to work, but she's doing very well. The NT-proBNP values went down. You can see there that is now around 1,000. I would say that she is in functional class 2 or 1 plus. That's what I would say. And we have also performed very recently a new exercise test, and these were the results, which actually have improved remarkably. It's not normal, but now she's doing very well, and obviously is not living with the immunosuppressors medication and all that of the heart transplantation, which was the other alternative that we had for her. So I think that was a good idea. We were concerned about some reports from the Mayo Clinic saying that they had to implant the ventricular assist device after this operation. So we had been following her, and actually this was the last echo. This was from last week, and you can see that the left ventricular function, I will say that is a little bit impaired, but actually it was 50% by echo. And this has helped us to try to offer this operation to other individuals. We have operated 3 individuals. This one was the last week, which was a 76-year-old woman with some overweight and, again, apical hypertrophy, shortness of breath. We had tried everything except disopyramide, or actually I don't know if we have tried on her. I should check. And we offer again apical myectomy. We were able to perform a 3D reconstruction with these printers that are now available. And you can see here, this was extracted from the MRI, and you can see here that the cavity was so small that you can find, well, you can understand that this is impossible to give enough blood to the body with every beating, and you can see here this was previous the myectomy, and this is an echo contrast at the coronary care unit after the operation, and she was discharged one week after. So we are happy. Anyway, obviously this is a very selected technique, only available or routinely performed only that I'm aware of at the Mayo Clinic. And obviously the candidates have to be selected very well. And also what doctors have told us is that it's more unpredictable to say which individuals are going to respond to the technique in contrast to what happened with the conventional myectomy procedure. But to our knowledge, or what we have seen in the 3 cases that we have operated, it's some improvement in the class, in the functional class, and obviously some diastolic volume improvements and cardiopulmonary exercise improvement. So here is our team of the cardiomyopathy and inherited cardiac disease unit at our center, and thank you very much. I don't know if you have had patients sent to the Mayo or operated at your center with this pattern of hypertrophy.
So, no, we don't send them to the Mayo Clinic.
Okay.
We have a superb surgeon, Prem Shekhar, who has done very few of these operations, as has anyone around the world, obviously. I'm curious, though, from the flail mitral leaflet, do you think that they attempted to reduce the papillary muscle as well?
Yeah, I think what happened is that they touch the papillary muscle and probably they cut.
But was that intentional? Because in hearing the Mayo Clinic talk now and then, they have moved to sometimes reducing the pap muscle thickness, and in her echo, it looked like that was. I'm just curious if that was frankly, intentional. Not that
Yeah.
they would have a flail valve being intentional, of course, but
Yeah, I think they did. I think they tried
to try and
do
reduce that as well.
Yeah.
So they were doing apical, and which is a pretty aggressive
Yeah,
approach.
it's really, it was really scary.
I will also say that we have had some patients, not many again, but who have had other manipulation of their apex, and we have also seen aneurysm develop down there. So that's something I think,
to
in
follow.
addition to LV dysfunction, aneurysm formation is going to be something to worry about there.
In the second case, was that also a compound heterozygous? Do you know the genetics?
Oh,
of
the
second
genetics
case?
of the second case. No, I don't think it was a compounded heterogeneity on that one, but I don't remember if we had the genetics on that lady. No? Yeah, okay, so, but I can check. I can send you an email and tell you. Okay. Certainly, the third case that we had operated, interestingly, I did the clinic today, and he came to the clinic today, and I was, oh, fantastic, because I'm going to tell how you're feeling. And the third case was a normal single mutation in the beta massin gene. So I don't think it's something linked with a specific hypertrophy pattern. Okay, thank you.
Pablo, I have a question from Salamanca, if it is possible.
Of course.
Well, thank you very much for the case. I have, in fact, two questions. First of all, as the woman was implanted, has an ICD implanted, have you observed any ventricular arrhythmias after surgery? And second, just imagine that the patient would have not an ICD implanted because she was in an intermediate score. Would you implant to these patients an ICD after surgery just because of the surgery?
That's a fantastic question. Yeah, very interesting. Thank you. Why we decided to implant? Well, we discussed with her the risks, and we decided to go for the ICD after extensive discussion with her. I think it was very important for her. I mean, the maternity came away at that stage, and for her it was extremely important to be completely sure that she was not passing away. So that obviously played a role in the decision. We were happy to have the ICD because we were scared about that, any potential arrhythmias after the operation. But I must say that there hasn't been any ICD discharge so far after the operation. And the second patient that we operated, this man that came today to the clinic, he does not have an ICD. He's older, he's around 70, and he has non-sustained VTs on halters, but this has not increased after the operation. And the lady that we operated 2 weeks ago, who is so old, doesn't have an ICD implanted, and we are not planning of implanted an ICD in somebody so old. And I think that were your questions. Yeah.
I wanted to ask regarding this hypothesis of the role of delayed relaxation in the pathophysiology of the sarcomeric disease and new drugs coming up. Having the opportunity to ask you, sitting both there, do you have any sort of proofs of concept that eventually when you target relaxation you can induce reverse remodeling to the ventricle as a way of, that would be a true proof that that is the main pathway?
That would be a wonderful experiment to do. The only way we can do that is right now in mice, okay? And there are some development of pigs in which those studies will probably be more informative. Mice, as you know, are not as susceptible to these mutations. The myosin mutations are in a different isoform. It's an alpha because that's the endogenous one expressed in the ventricle. And more importantly, their whole calcium hemodynamics is such that you can get rid of phospholamban in these animals and nothing happens. So their ability to extrude calcium through the sodium calcium exchanger is so great that they really don't get diastolic dysfunction the way we do. And so I can't answer you that. I can tell you that we have seen some, not a lot, because they're not long-term studies, but we have seen some regression of hypertrophy in the mouse models after giving the 461 mavacamten to mice with established hypertrophy. But the diastolic tension is just not something that you can do in a mouse.
Just to add to that, another way to think about it is we actually really don't know what the cause of left ventricular hypertrophy is in many instances. Is it the fibrosis or is it the increased myocyte size or both? I like to think that, as Greg said, there is a little bit of remodeling in mice. I like to think that you're seeing the diminution or the hypertrophic cardiomyocytes are probably getting somewhat smaller in size, but it would be very unlikely. In fact, histologically, we can say quite clearly, we don't reverse fibrosis. So, so the little bit of remodeling that we see is probably due to the change in some of the mice, but where humans will fall in that scale, I don't know. I like to say that at Harvard Medical School, we need never have another hypertrophic mouse.